Sọc xuyên qua bên sọc chân. Đi ban phòng. Đi ra. Rồi. Tập vào.
Hey, hi everybody.
We cracked it. As
Oh, very good. We are so, it's so good to see all of you together. This is amazing.
Where's Norman? Norman, we need you. Dear Grace is waiting to see you. Hello, Grace.
It's really nice to see all of you together.
Yes.
I really wish I was there. Oh my God, this is so nice.
So were you able to sort out the all the mess we created on
Yes.
Wednesday?
On our video, I think Mateo was able to, but Sasha was without connection, so he didn't forward Justin's videos to Mateo. I just asked for him now, so Sasha sent to me, so I will try to myself when it's written, this is Justin video, I will change my screen. But I'm at the hospital and my hospital blocks absolutely everything. I cannot download anything. So I'm using the internet of my cell phone. So hopefully we are going to have connection throughout everything, but we'll try.
Well, if there's a problem at the end, we could show Justin's videos after the Matteo's thing has been completed.
Yeah, I think he can after the video on YouTube, he can cut and add. But for today, for the audience, I will try to show from my end.
Okay, we're in your hands.
I hope it works. I really hope it works. Sasha has been very busy in Mauritius with the mission trip, and the internet is not good. And he was not expecting the internet to be bad. So that's the biggest thing. So otherwise, he would have planned things differently.
Is Adrian with us?
I don't know. Not yet, at least.
He told me he would be. I've sent him my PowerPoint, so he's been making. He knows what he has to comment on.
Just a second. And I'm on call and I have a sick kid. Hello. Okay, tell me.
My computer.
Okay. Okay. Okay, thank you. 25,250. Thank you.
Okay.
I'm so sorry today, guys, because I'm on service and the unit is very busy. So if I disappear, it's because, dear, the caution of the ECMO kit is very low. The laboratory just called me. Can I just check on the computer and make the caution? Yes, ECMO kit. But check on the computer, okay? Okay, thanks. Sorry.
Well, we're in your hands, Grace. You're in charge.
Okay, I think we are going to be able to start. I'm not going to play music because my connection is not that great. So hi, everybody. Welcome to Congenital Heart Academy. I apologize in advance because today the connection possibly is not the best. And we had some issues with the videos as well, but we are going to try our best to give you a good experience in this very interesting topic. And today is a very, very nice day because a lot of people are together. So we can see Dr. Anderson, Diane, Justin, and Dr. Norman all together. So this is amazing. I really wish we were there to complete that. Everybody smile for my picture, please. This is so nice to see all of you guys together. So Dr. Anderson, do you want to say some words before we start or can go straight to the videos?
I think we can go straight to the video, Grace. You're in charge. So as you say, we should apologize for some potential glitches because we had difficulty in patching this together, but we are sure you have everything in hand.
We hope everything goes okay. So thank you guys for joining us today, and I'm sure everybody's going to learn a lot.
Well, good afternoon to you all, ladies and gentlemen. This afternoon, at Gracie's request, we're going to present to you the anatomy of the conduction system. And understanding the anatomy is very much a 20th century affair. So at the end of the 19th century, there were several questions. We didn't know whether the cardiac impulse itself was conducted myogenically or neurogenically. We didn't know where it came from, and we didn't know how it crossed the atrioventricular junctions. Now, the first of those questions was resolved by the experiments of Stanius using the frog heart. He was able to show that the impulse was itself conducted myogenically, but influenced by neural activity. The matter of the conduction from atriums to ventricles was then the topic of much discussion in the latter part of the last decade of the 19th century. So two sets of important findings emerged in 1893. But sadly, they produced confusion rather than clarification. And this was a debate between Wilhelm Hist Jr. and Arthur Stanley Kent. Now, Wilhelm Hist Jr. had a strong scientific background. His father was the foremost embryologist of the 19th century. And his son, working in his father's department, had found a solitary bundle crossing the atrioventricular junctions. As you will see, he gave an illustration of that bundle, but at the time, it was not necessarily understood. In contrast, Stanley Kent was a physiologist. He was working at St. Thomas's Hospital in London, and he thought he had found multiple connections in the normal heart responsible for atrioventricular conduction. Sadly, he did not illustrate them in his initial presentation, but he did show pictures in subsequent presentations made to the Physiological Society. And here is one of his pictures that is showing the parietal part of the right atrioventricular junction. And it's interesting to note that what Kent labels is a node. And as we will see, node-like structures do indeed exist as illustrated by Kent. But what Kent failed to notice was that in his demonstrations, there were strands of fibrous tissue that were insulating his node-like structures from the atrial myocardium. And we'll come back to that. But let's go back to the account provided by Wilhelm Hist. This is the translation of the important passage. It was, of course, written in German. But if we look at the translation, we see that Hist is describing a bundle of cells. And you see he describes how it forks into right and left limbs at the base, the aortic cusp of the mitral valve. And here is his picture showing precisely that. You see he's shown us a nice 4-chamber cut through the heart. You can see the offsetting, the tricuspid and the mitral valves. And there at the base of the aortic leaflet of the mitral valve, as Hist describes, you see this entity which is on the crest of the muscular ventricular septum. And this is an accurate illustration, as we will see. But at the time, it was not fully understood. Indeed, it was not fully understood by this man, who is Arthur Keith. And Arthur Keith was a cardiac anatomist working at the London Hospital. a very distinguished cardiac anatomist. And he had been asked by Mackenzie, the foremost cardiologist at the time, who had come down from Burnley in Lancashire to practice in London. And Mackenzie, who was very interested in cardiac rhythm, had asked Arthur Keith to look for this bundle, so-called bundle of His. So Keith set about dissecting the human heart. And as you see, and this is a passage from his autobiography, in all of his dissections, he had been unable to find the so-called bundle of His. So as Keith says, he was skeptical of its existence. So he sat down and he penned a letter to Lancet telling him of his skepticism and saying that the bundle did not exist. Fortunately, before his letter could be published, again from his autobiography, you see he had been sent a paper from Professor Aschoff. Now, this is Ludwig Aschoff. He became the foremost cardiac pathologist in the first half of the 20th century, responsible, of course, for discovering the Aschoff nodule of rheumatic fever. But the account sent by Aschoff, in fact, came from a Japanese. And as Keith describes with the account before him, again and again, he was able to verify the system that had been described. So this is the young Japanese, Sanao Tawara. He had studied in Tokyo. He was initially intending to be a dermatologist. He had come to study with Aschoff in Germany. And Aschoff set Tawara the task of discovering the substrate for cardiac failure. So he set to serially sectioning hearts from various animal species. And this is the result of his labors, das Reitleitung system, das sagte Herzen, the conduction system of the mammalian heart. Now, I first came across this book when I was a BSc student at the University of Manchester. And it is a dense book made up of about 160 pages of German description. What I did not appreciate when I first read the book is that wrapped together in the back covers of the book are a series of the most beautiful plates. And here is one of those illustrations from those plates. I've reorientated it so that the atrial myocardium is to the left hand, the crest of the ventricular septum to your right hand, the right side of the heart to the top, the left side of the heart to the bottom. So there in yellow, you see that Tawara has depicted the atrial myocardium. And this is the structure that he discovered. He called it a knoten. We now call it the atrioventricular node. And you see that it's carried on a plate of insulating tissue in purple. But what Tawara showed was that his knoten became continuous with the connecting bundle as described by Hiss. It penetrated the plane of insulation. As Hiss said, it forks into right and left branches on the crest of the muscular ventricular septum. But Keith was not finished. He had endorsed the findings of Tawara, but he was intrigued to know where the heartbeat originated from. So he continued his studies with Martin Flack, who was a medical student working with him at the London hospital. Now, Keith had a holiday home in the country, and he was with Flack one weekend, and Keith and his wife, Celia, had gone for a bicycle ride, again from his autobiography. And you see that he describes as he and Celia returned from their ride, Keith, rather Flack, was very excited. He had discovered a wonderful structure, interestingly, in the auricle of a mole. So Keith and Flack continued to work, and they looked at sections from various species, including man. And this is a picture they made of the human heart. We're looking at it from behind. So you see the left atrium to the left hand, the right atrium to the right hand. There's the superior caval vein, the inferior caval vein, right atrial appendage. And between the systemic venous sinus and the appendage, you see the terminal groove. Diane very shortly will be showing you a dissection precisely like this. But I'd like to draw your attention to the section, teeth and flak made across the terminal groove, because this is the wonderful structure that they found. That is the terminal crest. There is a prominent nodal artery, and there you see the sinus node. And we can replicate their figure. This is a similar section made by my good friend and colleague, Damian Sanchez-Quintana. We've looked at his sections before. We'll see several more during today's presentation. There you see the terminal crest. On the left hand, you see the wall of the superior cable vein. You see again that prominent nodal artery, and there is the wonderful structure which we now know is the sinus node. We also now know that within the terminal crest, there is a paranodal area, and that is also important for normal nodal function. But what we really need to know is the location of the sinus node within the terminal crest. And that is what Diane is now going to show you in a dissected normal human heart. And then Justin is going to show you how you can see exactly the same thing now using virtual dissection.
Here we're looking at a morphologically right atrial appendage with its blunt or triangular tip and the broad junction with the venous component. Here is the superior cable vein entering the right atrial roof and the inferior cable vein, its floor. Along that broad venous junction, you can appreciate the terminal groove. And within the atrium, anterior to that groove, will be that prominent muscle bundle known as the terminal crest. At the cavoatrial junction, you can see the crest of the atrial appendage. And just inferior to that, and within the terminal groove, is the sinus node, which is a cigar-shaped or elliptical structure located in the subepicardial tissue. This dissection was made by removing the epicardial tissues from the atriums. So here's the left atrium with the pulmonary veins and the right atrium with the superior cable vein entering its roof and the inferior cable vein its floor. Along the broad venous junction between the morphologically right atrial appendage and its venous component, there is the terminal groove. And just anterior to that, you can see the prominent muscle bundle, which is the terminal crest from which the pectinate muscles extend. At the cavoatrial junction, we can see the crest of the appendage on the right, and just inferior to that and in subepicardial position is the location of the sinus node. The sinus node arterial supply can come from either the right or the left coronary artery system. And here you see the sinus node artery emerging from some of those muscle bundles that are crossing the interatrial fold. This vessel arises from the circumflex branch of the left coronary artery and extends to supply the sinus node.
So just a second, guys. Now you're supposed to have the first video from Justin. I'm just trying to find it here. Video 2, right? Yes, this one.
In this CT data set of a normal adolescent, we've filled the blood pool and we're looking directly anterior at the surface of the anterior aspect of the heart. And if we rotate this rightward into a right anterior oblique view, we start to see the right atrioventricular junction. And we can see the right coronary artery coursing within the anterior aspect of this junction and then wrapping around to the inferior aspect of the right atrioventricular junction. We can see the broad-based right atrial appendage and the superior and inferior cable veins. We'll continue to rotate this into right anterior oblique view, and we'll make the pulmonary vasculature translucent so we can visualize the pertinent anatomy. So again, we see the broad-based right atrial appendage, the superior and the inferior cable veins. The crest of the right atrial appendage, which abuts near the junction between the superior cable vein and the right atrium, is the location of the sinoatrial node on the epicardial surface. We can appreciate the terminal groove, which is running between the superior to the inferior cable vein here. On the inside of the heart, we would see that as the terminal crest. And at the superior aspect of the terminal groove is the crest of the right atrial appendage, where we said before, the sinoatrial node will sit near the crest on the epicardial surface.
But you've seen the location of the sinus node. But what now in the 21st century about the atrioventricular conduction axis as described by Warren? You will remember that his book was published in 1906. By the end of that decade, his account had been verified not only by Arthur Keith, but also by Walter Koch, who was another German pathologist. And this is the picture from the publication of the right atrial appendage. And Koch is showing its tail running down of the atrioventricular node. And Koch described the importance of this structure, which we now call the tendon of Todaro, which Koch called the Sinoatrial. It was part of a nodal triangle. The other side of the triangle is the hinge of the septal leaflet of the tricuspid valve. At the base of the triangle was the coronary sinus. And within that triangle, we find the atrioventricular node. So let's look at how accurate was this account provided by Walter Koch. And so now again, Diane will show you this dissection as seen in the normal human heart. And then Justin once more will show you how we can identify these structures now using virtual dissection of computed tomographic data sets.
This is the opened right atrioventricular junction of a normal heart so that we can show you the landmarks that mark the triangle of Koch. The flap valve at the floor of the oval fossa is here, and here is the mouth of the coronary sinus, which forms the base of the triangle. The other two arms of the triangle are formed by the hinge point of the tricuspid valve and the tendon of Todaro, which is a fibrous structure running deep to the eustachian valve. And if I tug on the eustachian valve, you can see that tendon lifting up and pointing directly at the apex of the triangle of Koch, which is where our atrioventricular conduction axis is located. The floor of the triangle of Koch is lined by fibrofatty tissue and is forming the inferior pyramidal space. So you can see by lifting away that endocardium that there is fibrofatty tissue within the floor of the triangle of Koch or in the inferior pyramidal space. And that fibrofatty tissue will extend in from the inferior right atrioventricular groove so that the fat within this inferior pyramidal space will also carry the artery to the sinus, or to the atrioventricular node rather. If we look at the left ventricular outflow tract of the same heart, we can see where the inferoseptal recess is located. And this is the area of the inferoseptal recess. And when the aorta is incorporated into the left ventricle or wedged between the atrioventricular valves, it lifts the mitral valve away from the septum so that this positions the membranous septum between the left ventricular cavity and the right atrium along this posterior inferior border of what is the membranous septum. So the membranous septum lies beneath the interleaflet triangle between the non-coronary aortic leaflet and the right coronary aortic leaflet. There's the right coronary orifice. So that at the borders of the right fibrous trigone and the membranous septum, we have the central fibrous body. And in this area is the inferoseptal recess. And I should mention that in this, the area of the inferoseptal recess is where the tricuspid and mitral valve have a small area of fibrous continuity. This special dissection is showing us a virtual long axis echocardiographic simulation of the left ventricle. So here's the right ventricular outflow tract, the aortic root as it's leaving the left ventricle. And here is where I have removed a portion of the atrial septum. So this is the area where the flap valve of the floor of the oval fossa would have been. I've left a portion of the anterior inferior muscular buttress. And here's the mouth of the coronary sinus where it enters the cavity of the right atrium. In this area, you see this large fibrofatty tissue plane, which is the floor of the triangle of Koch, or the inferior pyramidal space. And you can see how the fibrofatty tissue from the inferior atrioventricular groove extends into that inferior pyramidal space. Also, we can see the inferoseptal recess, which lies just here. And I've removed the majority of the mitral valve so that we can see this small flange of that aortic leaflet of the mitral valve where it's in fibrous continuity with the aortic valve. The membranous septum lies at the base of the interleaflet triangle between that non-coronary and right coronary aortic valvular sinuses. So there you can see the right coronary orifice. And where the mitral valve anchors itself towards the base or the posterior inferior border of the membranous septum is where we have the right fibrous trigone, and where those two structures join is the central fibrous body with the inferoseptal recess extending from it. In this area is where there is a small fibrous continuity between the tricuspid and the mitral valves. And here you can see nicely how the apex of the inferopyramidal space overlaps the base of the inferoseptal recess. If I show you another special dissection, which is a short axis view from the base of the heart, we can see the tricuspid valve, the mitral valve, and how the aorta is deeply wedged between the two atrioventricular valves. I've removed the non-adjacent or the non-coronary aortic valvular leaflet and sinus. And you can see nicely how that aortic leaflet of the mitral valve is lifted away from the ventricular septum, secondary to the aorta being incorporated into the left ventricle. Here is the area where we would have the inferoseptal recess, and here is the inferior pyramidal space. Again, you can see that fibrofatty tissue extending from the inferior atrioventricular grooves into the floor of the triangle of Koch or the inferior pyramidal space. Within that space, you typically see the artery to the atrioventricular node. You can see it branching from the distal right coronary artery in this case and running to the apex of the triangle of Koch. Also at the apex of the triangle of Koch, you can find the membranous septum. And here I have it cut in half so that my probe is pushing on the interventricular components, and the tricuspid valve would have crossed it in this area and bisecting the interventricular component from the atrioventricular component, which we're looking down on right now. So you can see how that membranous septum separates the cavity of the left ventricle from the cavity of the left, or of the right atrium, I should say, at the apex of the triangle of Koch and along the posterior inferior border of the inferoseptal recess.
What Diane and Justin have now shown you is the import.
Dr. Anderson, Justin's videos 4 and 5, it's now.
Yes.
Okay, so I'm going to show now.
We'll use a series of 3D virtual dissection reconstructions to review the landmarks of the triangle of Koch and discuss how they relate to the inferior pyramidal space in the inferoseptal recess. And we'll entertain the concept that the triangle of Koch is really a three-dimensional pyramid of Koch. And so here we have the free wall of the right atrium and right ventricle removed, looking in a right anterior oblique view at the rightward aspect of the interatrial and interventricular septums. We can appreciate in this next image, if we make the myocardium translucent, the floor of the oval fossa and how it's encircled by a C configuration by the superior, posterior, and inferior interatrial infoldings, which have in this patient epicardial fat within it. We can appreciate, if we come back here, that the aortic mound formed by the non-coronary sinus is found superior and anteriorly around the floor of the oval fossa, and then directly anterior is the muscular buttress. And that leads up to the tendon of Tadaro, which is overlaid by the eustachian ridge, which continues down inferiorly to the more recognizable eustachian valve, which guards the mouth of the inferior caval vein. So the eustachian ridge in the underlying tendon of Tadaro marks the posterior confine of the triangle of Koch. The anterior border is marked by the hinge line of the septal leaflet of the tricuspid valve, which I have marked in pinkish purple. The inferior aspect of the triangle of Koch is the mouth of the coronary sinus, which I've marked here in purple. Anterior to that is the caval septal isthmus, which is the location of the slow pathway and the slow inputs into the AV node. The AV node is often located directly posterior and inferior to this blue structure, the blue structure being found at the apex of the triangle of Koch, and that is the membranous septum. The membranous septum often has both the interventricular component, which is seen anteriorly here, with the septal leaflet hinge line crossing it and marking the posterior aspect being the atrioventricular component, which if we poked a hole through here, that hole would be communicating between the left ventricle and the right atrium. And so the AV node is often located posterior and inferior to the membranous septum within the triangle of Koch. And as we've made the myocardium translucent, we can see the structures that are contained within this three-dimensional pyramid of Koch, namely being the inferior pyramidal space, which is this heaping up of epicardial fat. We have epicardial fat both within the inferior right, and we can't appreciate in this view here, but the inferior left AV grooves, which if I rotate here and make the myocardium translucent again, we can appreciate that inferior left AV groove with the epicardial fat and how it heaps up into this inferior pyramidal space between the left and the right atrioventricular junctions. And just posterior to this left inferior AV groove, we can appreciate that purple color. And if we rotate, you can see that that is the coronary sinus running within that left inferior AV groove and then opening up into the right atrium, as we saw previously. So we'll come back to this view. So the inferior pyramidal space, its apex is directed superiorly, and at its apex is the location of the atrioventricular node. The nodal artery often runs within this inferior pyramidal space up to its apex to reach the AV node. We can also appreciate this structure, which I've colored orange, which is a left ventricular structure. We've talked about this previously, and if we come over to the left ventricular outflow tract, we can see this orange colored structure, which is the infraseptal recess. The infraseptal recess is the fibrous continuity between the mitral and tricuspid valve, specifically the aortic leaflet of the mitral valve and the septal leaflet of the tricuspid valve. And this has a downward directed apex, which overlaps on the leftward aspect of the upward directed inferior pyramidal space apex. We said the AV node is going to be found at the apex of the inferior pyramidal space. The penetrating bundle will then penetrate through the anterior right aspect of the infraseptal recess, and the non-branching bundle will then course to reach underneath the inferior margin of the membranous septum, and I'll rotate it here so we can see the blue colored membranous septum, and it'll rise along the crest of the ventricular septum towards the anterior aspect of the membranous septum along its inferior margin to give origin to the left bundle branch. The superior fascicle will then wrap around the left ventricular outflow tract towards the base of the superior lateral papillary muscle. The right bundle branch, if we come back over into this right anterior oblique view, we can see the insertion there of this papillary muscle, the small papillary muscle, which is supporting the septal and the anterior superior leaflet of the tricuspid valve. That is the medial papillary muscle, or papillary muscle of Lancisi, or papillary muscle of the conus. That's an important landmark for the surgeon because the right bundle will emerge underneath this papillary muscle and then course down the septal marginal trabeculation and across the moderator band to the free wall of the right ventricle. So these are the important structures that are within the confines of this three-dimensional pyramid of Koch, which is overlaid on the leftward aspect by the infraseptal recess. And if we pay attention to the infraseptal recess, it's along its superior margin, which will abut up to the virtual basal ring plane of the aortic root. Its posterior and leftward aspect is the location of the right fibrous trigoon, which is the right lateral thickening of the attachment of the aortic leaflet of the mitral valve, which is spanning the between the left fibrous trigoon and the right fibrous trigoon is spanned by the aortic mitral fibrous curtain, that area of fibrous continuity between the aortic leaflet of the mitral valve and the aortic valve. The anterior and right aspect of the infraseptal recess is the location of the membranous septum. These three structures together, the right fibrous trigoon, the infraseptal recess, and the membranous septum together form the central fibrous body, important landmarks to understand the conduction system. And then lastly, we'll look more closely at the components of the central fibrous body. So this is a two-dimensional three-chamber view looking at the left atrium, the left ventricle, and the aortic root. We're cutting almost midway between the anterior or aortic leaflet of the mitral valve, which is in fibrous continuity with the aortic root. We'll start to move medial towards the right fibrous trigoon, which I've marked here with this white arrow. And we'll go to a 3D reconstruction. That same arrow is now orange. That marks the right fibrous trigoon, which is again the rightward aspect of the lateral thickening of the aortic leaflet of the mitral valve, which is one end of the area of the aortic mitral fibrous curtain. We see that colored orange infraseptal recess. We'll come back to our two-dimensional image now in a four-chamber cut, and that is that mark for the right fibrous trigoon. I'm now going to continue to move medially towards the infraseptal recess, that orange colored structure. So we'll start to see this area here, this area of fibrous continuity between the aortic leaflet of the mitral valve and the septal leaflet of the tricuspid valve. So this is the beginning of the infraseptal recess. I've marked it here. This is a white arrow. On the colored three-dimensional image, it'll be a red arrow. So now we'll go to our three-dimensional image. So here we see that red arrow, which was marking the infraseptal recess, which is in a much different location than the right fibrous trigoon. So these are different structures anatomically. They develop from different structures developmentally. Again, the infraseptal recess being the area of fibrous continuity between the AV valves. So these again are the three components of the central fibrous body: the right fibrous trigoon, the infraseptal recess, and the membranous septum.
Of the inferior pyramidal space. So I am now showing you sections illustrating the relationship of the makeup of the atrioventricular node and the conduction axis relative to that inferior pyramidal space. Because there you see the space. It's filled by fibroadipose tissue. To your right hand, you see the crest of the muscular ventricular septum. And the inferior pyramidal space is between that crest, muscular ventricular septum, and the diverging vestibules of the right and left atrioventricular junctions, as you've just seen in Hans' dissection and in Justin's virtual dissection. But now we can look at the histologic makeup of the atrioventricular node. Because there to the top, you can see the tricuspid vestibule. And within the tricuspid vestibule are a column of cells that we can trace, as you will see, into the atrioventricular node. And this is the rightward inferior extension of the node. Underneath, you see the vestibule of the mitral valve. And within that myocardium, also, we have a second column of cells. And this is the leftward inferior extension. Now, this is part of a series of sections that Damian has made as we move upwards towards the apex of the triangle of Koch. So here is one of those sections moving through the triangle of Koch. And then now you can recognize the tendon Cotero, the Sinoatrial, as described by Walter Koch himself. And we can now see how those two extensions have come together, carried on this insulating tissue, as was shown by Tawara himself, and they have formed the compact atrioventricular node. You also see, however, that now we have connections into the node from the atrial septum itself, from the buttress of the atrial septum. And we're going to see very shortly that that buttress is carried on the roof of the infroseptal recess that was shown to you by Diane and by Justin. But I now draw your attention to this additional tongue of fibrous tissue, because you see it's covering over the rightward margin of the atrioventricular node. And that is important because that eventually will fuse with mitral to tricuspid valvular continuity and will insulate the conduction axis. And that is another important point. How does the node become the bundle of His? But Tawara also provided the answer for that, because as Tawara indicated, the node becomes the bundle once it is insulated. And so if we return to the same series of sections made by Damian, we can see that precise mechanism, because there is the tongue. It is now completely surrounded the atrioventricular conduction axis, and it has fused with that area, mitral to tricuspid valvular continuity, that is forming the roof of the infroseptal recess. And by that process, it has insulated the conduction axis. So now it is the bundle, connecting bundle, as initially described His. Or if I take another of Damian's serial sections, I can show you what happens to that bundle as it extends still further beyond the apex of the triangle of Koch, because now it has penetrated. And now it is in the rightward wall of that infroseptal recess that was shown to you by Diane and by Justin. And now it is beneath the atrioventricular component of the membranous septum. There you see the septal leaf of the tricuspid valve that separates the membranous septum into its atrioventricular and interventricular components. So there is the bundle, but now it is branching. It is branching on the crest of the muscular ventricular septum, and here you see it giving rise to its left limb. But if we go a little bit more anteriorly, still you see the infroseptal recess, the atrioventricular component of the membranous septum. But now, as was described by His himself, the bundle has formed. Now it is giving left bundle branch and right bundle branch. So how do these bundle branches relate to the aortic root itself? But once again, Tawara has provided us with the answer. So here is another of those beautiful plates wrapped together in the back of the book that Tawara wrote on the conducting system of the mammalian heart. As I say, this also I missed when I first looked through that book. As a BSc student in 1963. I discovered it much later when I was working in Amsterdam in my formative year in 1973, 74, when I was working with Michiel Janssen, an electrophysiologist. And it is truly spectacular, as Tawara indicates the course of the atrioventricular conduction axis. He is showing this picture, of course, from the left ventricle, and he's opened out the aortic root. And if you look carefully, you can see dotted lines where he's shown you the location of the atrioventricular node, penetrating bundle, as we've just looked at it within the inferior pyramidal space and within the atrial septum. We've seen how it penetrates, and having penetrated, Tuara now shows us as he continues to have this close relationship to the nadir of the right coronary leaflet before it descends, the left bundle branch descends down the left surface, dividing into three fascicles, an inferior fascicle running towards the inferoseptal papillary muscle of mitral valve. Also shows this because we can now put the conduction axis back into the heart. That is what Justin will now show you.
Professor Anderson wanted me to briefly share some of our ongoing investigations of trying to understand gross anatomical variation, things that we can see, whether with direct visualization within the operating theater or by 2- and 3-dimensional clinical imaging that can help us to accurately predict the different components of the atrioventricular conduction axis and how they relate to the 3-dimensional heart. So Professor Anderson has reviewed much of our historical understanding of the conduction system. And as we started to revisit how that's been formed, we appreciated that much of it was based on 2-dimensional histology cut relative to the triangle of Koch. And while that's important and can accurately relay the proximal components of the inputs into the AV node and the AV node and penetrating bundle, it becomes difficult to relate the different components to the aortic root and the more distal components specifically. And so we recently published a paper in Clinical Anatomy where we initially used this historical method, cutting perpendicular or parallel to the plane of the base of the triangle of Koch. So that plane is shown here in this red line and shown in representative 3-dimensional virtual reconstructions in the right upper and 2-dimensional histology in the right lower panels. And you can appreciate how the aortic root is cut in a very oblique way, and that's going to depend on the variability in the rotational position, the wedging, and the tilt angle of the aortic root. So it's very difficult to try to relate the conduction axis accurately to the aortic root and the ventricular structures. So we modified our technique to cut how this yellow line is showing, which is perpendicular to the plane of the virtual basal ring of the aortic root, which with representative images in the left-hand panel. And we can appreciate how it cuts in a much more meaningful way relative to the aortic root. And in this study, we specifically showed how the left bundle and its superior fascicle has a much closer relationship to the aortic root, specifically the nadir of the right coronary leaflet than previously appreciated, on average being about 3.3 millimeters inferior to the nadir of the right coronary leaflet. And then using this understanding that we've discussed of this 3-dimensional concept of the pyramid of Koch and how that helps us to accurately understand the components of the atrioventricular conduction axis, we then went forward to a study which is currently under review. And so I obtained a handful of normal intact heart specimens. I scanned them with high resolution MRI. And then we cut the histology perpendicular to the plane of the virtual basal ring, first looking at the gross anatomy and paying attention to variation in the aortic root and the underlying structures. And we stained the histology in a spatial resolution, which was comparable to the spatial resolution of the 3-dimensional MRI data set. So then I was able to simulate the histological cuts and march through the histology and put the different components of the atrioventricular conduction axis back into the 3-dimensional heart. And we then reconstructed the different components of the pyramid of Koch and then accurately put the conduction axis back into the 3-dimensional heart to try to understand what variable features of the pyramid of Koch, of the aortic root and its underlying support could help us to accurately predict variability in the atrioventricular conduction axis. And I'm not going to go over the details of this unpublished study, which is currently under review, but we'll just briefly talk about some of the main findings. So we were able to divide the hearts up into those which we thought would be lower risk for conduction axis, where the conduction axis courses much more inferior to the virtual basal ring plane, which is shown here in green. versus those which were higher risk, where it closes near or even at or above the virtual basal ring plane. And then we looked at these different components of the pyramid of Koch and the central fibrous body to try to understand if those could help us to predict the course of the AV node, the penetrating bundle, the non-branching bundle, the origin of the left bundle branch, and then its superior fascicle as color-coded here. And we found very exciting findings, not only things like the infraseptal recess, its height, its width, and its depth, but also the membranous septum and its inferior margin, how that relates to the virtual basal ring plane. We also looked at the rotational position of the aortic root. So shown here, we're cut in a surgeon's view at the virtual basal ring plane. And if you look at the nadir of the non-coronary leaflet here in panel A versus B, you can see how there's significant variability in the rotational position like we've described before. That also relates to the width and depth of the infraseptal recess shown in orange. That also relates to the circumference of the different components of the conduction axis and how it relates to the different leaflets and sinuses of the aortic root, along with how much or little is brought into the circumference of the left ventricular outflow tract below the virtual basal ring plane. And then lastly, shown here in this figure where we've simulated device placement like in TAVR, and we've simulated at a similar depth. It's not only the infraseptal recess and membranous septum, which in these two hearts show very similar height, width, and depth, and very similar angle of the inferior margin of the membranous septum, but there's other components that help us to predict how the conduction axis will course. In these examples, you see how even though we have similar height, width, and depth of the infraseptal recess and a similar angle of the crest of the ventricular septum under the inferior margin of the membranous septum, in this heart, the superior fascicle then starts to slowly descend and course around the left ventricular outflow tract, while in this heart, it continues to ascend past the membranous septum up towards the virtual basal ring plane. So in this heart, the conduction axis would have been impinged upon, where in this heart, it would have been safe. So these features that we're excited to hopefully publish soon can be highly predictive to help us to accurately predict the different components of the conduction axis. So these are the two studies that are published that I've referenced, and again, excited to share the findings of this study under review.
As you've seen, we're now able to confirm the initial findings of Keith regarding the sinus node, Tuara regarding the atrioventricular conduction axis. But if we return to that first decade, 20th century, there was further controversy because there were arguments as to how the impulse made its way from the newly discovered sinus node to reach the atrioventricular node. And here again, it was a German who produced the controversy, a German pathologist called Tarell. As Tarell, 1909, suggested that there were specialized pathways running through the atrial walls between the sinus node, the atrioventricular node. Once more, however, he failed to provide convincing illustrations, and he gave no criterions for how he determined those atrial cardiomyocytes were specialized. So, in the final decade of the final year of the first decade of the 20th century, the German Pathological Society convened a meeting to discuss this problem. And the giants of cardiac pathology at the time, Aschoff, the mentor of Tuara, now joined by Munkeberg, said that a conducting system, an insulated conducting system, should be modeled on the ventricular system of Tuara. And to fulfill the criterions for such a conducting system, the cardiomyocytes, if they were making a tract, should be insulated. And that was what we have now seen with the atrioventricular conduction axis, or the connecting bundle for the bundle branches. The cardiomyocytes should also be histologically distinct and traceable from section to section. And that is important because the nodes I've shown you, sinus node, the atrioventricular node, are not themselves insulated, but I can recognize them as nodes, as did Keith, as did Tuara, because cardiomyocytes, as Ashoff and Munkerberg now emphasize, are histologically distinct and can be traced from section to section. So now, if I show you this cut across the right atrium of the neonatal heart, superior cable vein is to your left hand, bicuspid valve is to your right hand, there's the cavity of the right atrium, using those two criteria for distinction of nodes, cells that are histologically distinct, that can be followed from section to section, even at this low power of resolution. I can show you the sinus node, I can show you the atrioventricular node. But the remainder of the atrial cardiomyocytes are no more than ordinary working cardiomyocytes. There they are, making up terminal crest. Here they are making up the vestibule, the parietal vestibule, the right atrioventricular junction. And there they are making up the buttress of the atrial septum. And some of those cells, as you will see shortly, produce the fast pathway through the atrial septum, slow pathway through the extensions of the atrioventricular node, but they are ordinary working cardiomyocytes. And so the pathways for conduction from the sinus node to the atrioventricular node are not, as illustrated here, directly comparable to the ventricular pathways. Instead, the pathways from the sinus node to the atrioventricular node are determined no more than by the geometry of the right atrium. Because the right atrium is no more than a bag of myocardium with the myocardium separated by a series of holes. And that is now what Diane will show you by illustrating to you the morphology of the right atrium and showing you those potential pathways for conduction from the sinus to the atrioventricular node.
The right atrium has been referred to as a bag of holes with respect to the conduction tissues. You can see that I've removed a good bit of the endocardial tissue from the right atrial musculature to show you the prominent muscle bundles that surround these holes and allow for conduction to occur. So the muscle bundles are surrounding the superior cable vein, the inferior cable vein, which is opened in this case, the mouth of the coronary sinus, and here is the flap valve at the floor of the oval fossa. So those are the holes we are referring to, and you can see the muscle surrounding all of these areas. The terminal crest is that prominent muscle bundle that extends along the broad venous junction, and the slow pathway will extend along that terminal crest and through one of these prominent muscle bundles. And we know that when we reoppose the right atrium, that those prominent muscle bundles or pectinate muscles continue into the subthebesian sinus. So the pathway will continue between the mouth of the coronary sinus and the hinge point of the tricuspid valve. The other muscle bundles are those that extend around the rims of the oval fossa and in the areas anterior to it, which will mark the fast pathway.
So here we see a picture showing exactly what Diane has shown you. There are these pathways, terminal crest, pectinate muscles, the fast pathway through the buttress of the atrial septum, the slow pathway through the vestibules. So it is the pathway through the buttress of the atrial septum, the last connection is the fast pathway into the node, and it is those extensions that I showed you in the vestibules that are slow pathways. So let me finish our presentation on anatomy of the conduction system by returning to Stanley Kent. Because as I've explained to you, the structures he described do indeed exist. but they do not make muscular connections in the normal heart. Here is one of my pictures showing you such a node. And this is a section that is colored with what we call the Masson trichrome technique. Everything that you see in green is fibrous tissue. And you see that the node-like structure is engulfed by fibrous tissue because it is sequestrated within the vestibule of the right atrioventricular junction. And I can now tell you where these structures come from. Now, this is a picture, if you've been watching the Congenital Heart Academy over the recent months, you will have seen before, because this is a picture that is showing you the embryonic interventricular communication. And it's showing you the interventricular communication at the stage at which the atrioventricular canal is supported exclusively by the developing left ventricle. As you can see, it's a human embryo at 5 weeks of gestation. And I've told you with my colleagues in Amsterdam a long time ago now, we use the antibody to the nodose ganglion chick to demonstrate this ring of cells that surrounded the embryonic interventricular communication. And it is the fate of that ring of cells that solves the problem of the nodes of Kent. You'll also know that I've shown you that for the right atrium to gain its connection to the developing right ventricle, there has to be expansion of the atrioventricular canal. And this shows the situation after there has been such expansion, so that the cavity of the right atrium is now able to look directly into the cavity of the right ventricle. And that has spread this ring of cells. Now we can see that the part on the crest of the muscular ventricular septum is going to be the connecting bundle as described by His. But we can now see that the parietal part has become sequestrated in the parietal part of the right atrioventricular junction. And this is the origin of those nodes of Kent. They are sequestrated, usually within the atrial myocardium. But we now know that in rare circumstances, they can indeed produce muscular connections. They produce specialized muscular atrioventricular bundles, and they produce what we call Maheim conduction in the setting of ventricular pre-excitation. But that is an abnormality. It is not part of normal conduction. You can also see, however, that there is another part of that ring that is remaining, and that is behind the aorta, and it produces a structure that we now call the retroaortic node. And we still don't know what that does. So we still have things to find out. So if I summarize what I've shown you, we are still learning about the anatomy of the conduction system using new approaches, immunohistochemical, molecular biological. We have markers now that bring new important information. We still don't know the function of that retroaortic node, but we've resolved the issue of the nodes of Kent. What is important, however, is that as we use this new information, we put it into the knowledge that has now existed for more than 100 years. Because what I hope I've shown you is that those initial descriptions by Tuara, Aschoff, Munkeberg, also by Arthur Keith, were remarkably accurate. So we knew all about the anatomy of the conduction system in the first decade, 20th century. That retains its value, and that gives us the knowledge we now require to understand the anatomy of the conduction system.
Thank you very much, Dr. Anderson, Justine, and Diane. It was a very nice presentation. I'm very happy that my request was fulfilled, and I'm sure it's going to help a lot of people to understand better the conduction system. And I'm really happy to see all of you together there. It's really nice. So I think—
Good job in making things work, Grace. Congratulations on maneuvering all the videos.
Thank you. I'm happy it worked. On YouTube, guys, it's going to be much better because we're going to upload the video complete. It's going to be better to share with your colleagues and to watch again. And I just need to say something because I was very fortunate to learn pediatric cardiology, having Dr. Vera Yellow in the program where I've been. So I was able to see beautiful hearts as the ones that Diane was showing. So this is very familiar to me. But the images that Justin is bringing now, correlating what I saw on anatomy is really amazing. So it's adding a lot to the understanding and to the knowledge. So thank you for that, Justin. Thank you for that, Dr. Anderson, to think about it, to get these things together.
Thank you, Grace.
Adrian, I think Grace is ready. I don't know whether he's been advanced as a panelist yet. He sent a chat, but he had not been. I know he's available if you can advance him as a panelist.
Okay, Adrian, do you have something to show? I'm going to get him as a panelist. If you could just a second. Adrian, allowed to talk.
Hello, can you hear me?
Yes.
Hi, it's wonderful to see all of you there. Thank you, Grace.
Yeah, it's very nice, right?
Thank you, Justin, and Diane and Norman. It's amazing, especially on such a complicated lecture, because this is not easy, and I'm sure there will be a lot of questions that will go in each and every congenital heart malformation to tell us exactly where to put our stitches to get another heart block. But I'd like to ask first of all, to congratulate Diane and Justin. Really amazing images, and we need to go back on them because we have to analyze them closely. But they are very well prepared, so it makes our job much easier. I'd like to ask a few simple questions, and first to clarify that what we've seen for decades on echo, and Norman is there, thinking that the mitral somehow comes to the septum and we see the offset. That's actually what the recess does, because it allows the mitral not to be truly septal. We see that is an offset, but that's actually the infraseptal recess that does the work of linking the mitral to the septum and to the tricuspid. And that's an important aspect that we see, isn't that?
Norman, that's
well, I think it's very interesting to look at this study. The mitral and tricuspid valves, as you can see, come together in fibrous continuity on the ventricular septum. It's absolutely obvious. And I think that we've noticed that for a long time because the central fibrous body was described echocardiographically in 1977 by me. So I know that it's been described there. But the central fibrous body, as we see it echocardiographically now, has expanded to include the fibrous skeleton of the base of the tricuspid, the mitral valve, the membranous septum, that anterior infraseptal recess, and also this pyramid that you described so beautifully, which is the infraseptal recess. And I think that this is so beautifully put together. And I think that if that's answered your question, Adrian, what I want to say while I have the microphone is what a spectacular opportunity this lecture is for everybody interested in the conducting tissue. Because you have from Professor Anderson, who's a great scholar of history, by the way, we have this history that tells us that it was there all the time, that we didn't see it. Then you have from Diane this amazing group of dissections to show in 3 dimensions what the components are of the periconducting tissues and how easy it is to see. And finally, Justin synthesizing the whole thing in terms of which part of the conducting tissue is related to which. And for me, that has been a very dense, unfortunately, dense amount of information coming at you. And that's the beauty of, as I say every week, of the fact that you can go onto the YouTube channel and look at this again. and really dissect this in your own brain as to what you're seeing. I have nothing else to say.
Thank you. Thank you. The second thing is I now use for teaching the analogy with the common atrioventricular valve and the two junctions in order to explain the pyramidal space and the infraseptal recess. Because if I'm correct, when we have a common AV junction and an unwedged aorta, that pyramidal space and the infraseptal recess are effaced, are not that well defined. Is that correct?
That's absolutely correct. And then, as we know, in atrioventricular septal defect, the conduction axis is at the crux of the heart. So in the normal heart, as Justin has shown you, the penetration effectively is in the middle of the heart.
Yeah.
And as you say, Adrian, because when we have common atrioventricular junction, the inferior pyramidal space is effaced, so the conduction axis itself moves inferiorly, and it joins the atrial myocardium at the crux of the heart. So you're 100% correct.
And one last thing is about penetration, because we know that the bundle penetrates and it is insulated, but then there is a second penetration of the right bundle, isn't it, to get back to the right ventricle, or is not correct? And are the branches insulated as well or not?
In fact, the right bundle emerges from the myocardium, and you are correct that it is insulated, but that's not, in many respects, it's a continuation of the insulation until you reach the ventricular apexes. So those fibrous sheaths are part and parcel of the insulating tissues, but the initial insulation is at the level of the atrioventricular junction. It's as if then the bundle branches have gloves on until they reach the ventricular apexes, and only at the ventricular apexes do the tips of the fingers of the glove give way, so that then the conducting myocytes can interpose directly with the working cardiomyocytes.
I see. So is the right bundle branch penetrating the interventricular septum?
Sometimes it passes through the myocardium. In other instances, it is on the surface of the septum. And in the one particular heart I showed you, it was on the surface of the septum. In others, the branching bundle is carried below the crest of the septum, and then the right bundle branch will pass through the septum before it emerges beneath the medial papillary muscle. As Justin said, we're still working on this, and we're trying to put this back into the hearts, and that we're going to continue to do this. Justin, would you say any more about that?
No, I think you summarized that well. The one point I would emphasize is about the infraseptal recess in the normal heart. Something that we've published on looking at different animal species is that it often is not present in many animals, in like dogs and cows. But then when we come to the human, where it is most often present, there is marked variability, and Diane has a nice heart she's come across where there's lack, just like the dog, there's lack of that infraseptal recess. So those are things that we're trying to understand just in the normal heart, of how that variability could potentially increase or decrease the risk of iatrogenic damage on the conduction axis.
But the other point that Adrian has made is that now we need to extend these to look at congenitally malformed hearts. And that has already started being done. There is a group in Japan who have used synchrotron investigation to show the location of the conduction axis. And that's being done in atrioventricular septal defect and ventricular septal defect. I think we need to do this more. And Adrian, as you well know, this is something we would like to do in Birmingham. And we'd like to look at this in the setting of congenitally corrected transposition and isomerism. So the ability to see the conduction axis now using micro-computed tomography and doing what Justin is doing, combining computed tomography with histology, I think will permit us to more precisely put the conduction system back into the heart.
Absolutely. Thanks again. Can't wait to look at the papers, and I encourage everybody to look at them.
Sure. Bob, I wonder, you didn't say anything about the condensation of the AV node, of a ring of tissue, and how sometimes you have an anterior node and a posterior node. And you also mentioned AV septal defects, but in straddling valves, again, and in a lot of hearts where there's large interventricular communications, the conducting tissue follows the crooks of the heart, as you said. I just wanted to emphasize that point and have you.
In fact, you make a very good point there, Norman. It all relates to the expansion of that ring that I showed in my final few slides, because that ring and those nodes of Kent encircle the orifice of the developing tricuspid valve. So the point you make is a very good one, because a node can be formed, a connecting node, when the ventricular septum itself is malaligned. So from that ring of cells that I showed you, in which can describe remnants of them in some malformed hearts, as you now imply, parts of that ring can form either an anterior node or an inferolateral node. So you're right to emphasize that point. And it's something I did not mention.
We have
Grace, do we have some questions?
Yes, we have 2 questions. I know that you guys had another commitment in a few minutes, so we are just going to make one question, and we thank you very much for giving your time for us. So there's a question about what regulates the embryological origin of conduction tissue and what's the cell of origin?
Well, that's a very good question. My colleagues in Amsterdam have done a lot of work on that, and they've looked at the genes that regulate the repression, because when, as you know, during our discussions of embryologic development, we talked about the primary heart tube, and then we've talked about ballooning from the primary heart tube to form the atrial appendages, to form the apical components of the ventricle. And we know that there are genes that repress the initial primary heart tube, which is conducting myocardium, and only parts of that conducting myocardium persist. And it is those genes. Off the top of my head, I can't remember the genes, but the group from Amsterdam, Vincent Christoffels, Anton Moorman, have published extensively on this. So if people want to know about these repressing genes, they are TBX genes. There's a whole family of TBX genes, and the TBX genes, some of them repress the myocardium so that it becomes working myocardium. Others permit the initial primary myocardium to persist and to become the conduction system. I won't say anymore because I could well get it wrong, but it is all there, and it has been discussed at length by the group from Amsterdam.
Okay, thank you very much. Thank you very much for everybody who watched us today. And we're sorry for the technical issues. We are sure it's going to be better on YouTube. And please share this link with your colleagues, the link on YouTube, because it's a very interesting session. And I'm sure it's going to help a lot of people to understand this topic better. And thank to all of you. Thanks for giving your time. I know you guys are very busy these days, and we are very happy for that. And we are willing to continue this amazing series. Thank you very much, guys.
Thank you.
Thank you, Grace.
Bye-bye.
Wonderful session.